My name is Shohei Omokawa from Nara, Japan. Sawadee-ka. I'd like to share with you this morning about Trapeziometacapal osteoarthritis. I came from Nara as the first imperial capital in Japan and centrally located. Long time ago, we have many temples, as you know, and you can stop to Nara when you come to Japan to see the many Buddha. Here, big Buddha. And we take an X-ray, plain radiograph for the TMC joint. And this is a robot view, and not the PA, but AP view of the thumb. And in addition to the AP view, we take a best view like this from the lateral view of the wrist and the 40 degrees pronation and 40 degrees downward. We can see whole trapezium around the trapezium like this. Okay. This is a whole trapezial view. Why we take best view? It's a reliability of radiological staging. In addition to the AP and lateral view, if we take a best view, the cup value of internal stage is higher, like this. More accurate evaluation is possible. As you know, there are Eaton classifications from stage 1 to stage 4. And we selected treatment depending on the stage. However, sometimes we should be careful, like this. 52 years female. This is almost normal X-ray. However, when we take a arthroscopy, there is no cartilage in the half area. This is a very painful joint. And so we need to listen to the patient's complaint, not to the, depending on the X-ray, but the patient complaint is very important. This is another female, 43 years, almost normal, but the arthroscopy tells us very devastating status of the articular cartilage also. But in fact, we select a non-surgical treatment for the TMC-OA, like a brace, orthosis, the joint infection, injection, and the medication, using a very small needle of 26 gauge. The EBM of orthosis include a very effective for pain reduction, and the fitting and the compliance is very important for success. And I prefer the waterproof brace like this. And also, one study told us that 70 of patients who are waiting for surgery quitted surgery after 7 months bracing. And so we need to apply brace minimally 6 months before surgery. And also, EBM of the TMC joint injection says this is an effective treatment also, but we found no significant difference between saline, hyaluronic acid, and steroid. And so steroid is effective in a short-term period only. And so in my clinic, and the injection is only once tried, never try again. This is my method to try to inject. It's very important to the injection site. We need to inject internervous-plane here to avoid a nerve injury. Not from here, but from here we should inject. This is the point of the injection site. This is a TMC joint proximal border, the EPL, EPB. This is APB, and the radial, the palmar border of the APB, we can inject safely to avoid a nerve injury. And we can select surgical procedure depending on the staging. For the early stage, we do a ligamentous reconstruction and metacarpal osteotomy. And then for advanced stage, we select orthosis, arthroplasty, and trapezial resection arthroplasty. This is my patient. 20 years ago, I did a Eaton literal procedure for unstable thumb. She came to my clinic 20 years later. The result was very good, no pain, very stable and mobile thumb. And so Eaton procedure is a very effective procedure for early stage and osteoarthritis. But I now modify this procedure for more minimally invasive surgery now. And this is stage 2 OA. And the metacarpal osteotomy is a very good option for the joint preserving surgery. For advanced OA, stage 3, and there are mainly 2 procedures, joint fusion or trapezial resection surgery. Total resection is mainly conducted in the world. The advantage of this procedure is good pain relief, and the fusion have a stable thumb, and the resection surgery is a mobile thumb. But there are several disadvantages because the fusion have a more complication and may have adjacent joint osteoarthritis later after the surgery. And this procedure have a less stability compared to the fusion, and also the difficult salvage surgery if the patient have a very bad outcome, and there we have difficult salvage surgery after this surgery. And the Cochrane review recently compared many procedures about the trapezial resection and associated ligament interposition and ligament reconstructive surgery. And their conclusion was these all are comparable outcome. And the trapezial resection only have a less complication. And so we have no evidence of benefit in outcomes by additional procedure. It means that maybe the simpler, the better. The less minimally invasive, the better. So I started arthroscopic surgery 10 years ago, and because Dr. Desmonier they presented the arthroscopic surgery 10 years ago at the ASSH meeting, and I started 10 years ago. My procedure is now have 4 category for the arthroscopic, trapezial hemi-resection, and the tendon suspension by APL arthroplasty. First stage is synobectomy and free body resection. And secondly, we take the partially trapezium by 3 millimeter. And then we take a partial APL tendon, and then we fix the tendon, pull out to the second metacarpal base and fixed it by the interference screw. Again, internervous-plane approach is very important to avoid a nerve injury. And we use a 1.9 arthroscope here. This is a radiofrequency probe. And using this, the synobectomy was conducted. And then we take a trapezium from here to here, and we can see the second metacarpal base here, white body here. This is the second trapezium base. We take a trapezium by 3 millimeter like this, and then we harvest the APL tendon, and we need to pay attention to the variation of the APL tendon attachment. So accurate identification of the APL tendon is needed. We cut the tendon 5 centimeter and minimal invasive and pull out to this area, and the interface screw was fixed to the second metacarpal base. A reduction of the TMC joint subluxation is possible by suspension using APL tendon. Also, we can use artificial ligament such as tightrope is possible for elderly people. A post-op hand therapy included 2 or 3 weeks immobilization. After that, we start the post-operative hand therapy. This is an example, 57-year female, Eaton stage 3, dorsal subluxation and radially subluxed. And we need to remove the spur, 3 millimeter here. Then we fixed to the interference screw, rather and reduced. This is a post-op appearance, and very mobile, and the scar and surgical scar is very minimal. And for the elderly patient, more than 70s, I do use artificial ligament using tightrope. And the patient summary, I have now the more than 100 cases, average years 46, and stages like this, and for a period averaged 5 years. And functional outcomes included, and the VAS score for pain, dash, and grip power and pinch power improved post-op. And also X-ray evaluation and the joint space ratio improved, and also dorsal subluxation improved significantly. Arthroscopic surgery have an advantage such as minimum invasive, and both stabilization and mobilization is possible. And the drawback is need some learning curve and need more longer term follow-up. In summary, management of the TMC OA should be included in non-surgical treatment first, and adequate surgery should be selected depending on staging. And finally, the arthroscopic surgery have a feasible midterm outcomes, and both stability and mobility can be acquired. Thank you for your attention.